Done. Redirecting to Facebook Live. I believe we're live. Hi, Dr. Atkinson, Brad Goodman. Thank you for coming on DocTalk Live this morning. It's a pleasure to have you. I love your backdrop. How do you do that?
Well, I don't know. It's just one of those things that the Zoom video, allows me to put in an artificial a photo of my choice. So this is my favorite vacation spot out in Montana. So.
Oh, nice.
So,
do you ski out there?
No, I'm an amateur paleontologist, so I hunt fossils. Actually, I go out with a nonprofit out there to dig dinosaurs in the summertime sometimes.
That is so cool. Maybe at the end we can talk about that. I want to get to hereditary angioedema. So DocTalk Live, Dr. Atkinson, is a way for me and others to interact with just the lay people. And I had one of my listeners, one of my viewers, ask about doing a show on this particular topic, hereditary angioedema. And of course, I knew nothing about it, or I don't know much about it, and I didn't know how to tackle this. I asked Dr. Cron, who's been on the show before, for a suggestion, and he suggested you. So why did he suggest you? Who are you? Why did he bring your name to the forefront as a physician?
Well, I'm a clinical immunologist, and I've been around for a while, as you may be able to tell from the color of my hair. But I mean, I've worked with complement deficiencies a lot in the past, and I trained at the National Institutes of Health, actually under Dr. Fauci. I'll do a little name dropping, but yeah.
One of my colleagues in medical school was Rob Frank, who became a plastic surgeon. But Rob's dad was a doctor that I think discovered complement. Does that name ring a bell?
He didn't discover complement, but he was there. If you're talking about Michael,
yes, that would
Dr.
be his
Mike
dad.
Frank, he was actually the head of the program and interviewed me on my day when I was applying for fellowship there. And actually, I was just thinking this morning that I remember him describing the activity of C1 esterase inhibitor, which is the inhibitor that's involved in the most common forms of hereditary angioedema, and describing how it works and everything. It was a very great interest of his, and they had many patients there that we worked with.
Well, his son was a wonderful classmate. I'll say that.
Yeah, he was a great doctor. He went to Duke after he left the National Institutes of Health and was there for a number of years. He just passed away a year or so ago, unfortunately. He was a great doctor and researcher.
Okay, so let's get back to the story. So I interrupted you.
Sure.
Why am I here with you? Tell me, give me a little bit of
hereditary angioedema is an abnormality in a protein that's been thought of classically as part of the complement system. And the complement system, which is a system that most people have never heard of, is a part of the immune system that helps to protect you from infection. But this protein actually does lots of different things that don't actually have much to do with the complement system per se. And it's actually those other activities that have to do with the swelling part. But I think by default, clinical immunologists and allergists, because they deal with angioedema or swelling and hives and things like that, have kind of by default been the managers of patients with this rare and really life-altering disorder.
How can you tell us about a patient, how it presents, and what the typical pathway for a patient is?
Yeah, so the typical presentation, I guess, would be a patient who's maybe got a family history, in which case the diagnosis becomes pretty clear very early on with episodes of swelling, but not infrequently there's no family history. The person may have maybe the first person in the family to have an abnormality in the gene for this, the main gene that causes this type of hereditary angioedema. And so it's a mystery. Suddenly, usually in adolescence, this young person will develop absolutely massive swelling of the face or one hand or a foot. it's usually kind of asymptomatic. It takes days to resolve. Everybody is just totally dumbstruck, because it's out of the blue. And then these episodes begin to recur, and usually they get diagnosed. Now that there is actually a fair amount of literacy in the medical community now about this disorder. So, I don't think in that setting that it would take that long. The ones that are the most troublesome to diagnose are the ones that have the other presentation that's not too uncommon is abdominal pain, recurrent, terrible, incapacitating episodes of abdominal pain that again last for days. And this is because the bowel is always moving, presumably, and you have these little areas of micro trauma in the bowel, and they set off this swelling in the bowel that also causes, massive swelling in the bowel, which is accompanied by terrible pain. And so they go to the ER, and the ER gives them drugs, and you're constipated, or you've got some kind of viral infection or something. And it can take months and months or years before the patient really gets an adequate diagnosis sometimes.
So because there's a genetic marker now for that, it's easier to, if you have a suspicion for it, it's easier to rule in or rule out. Is that what you're saying?
Usually, yeah, there are some rarer kinds that are more difficult, but the classic form of hereditary angioedema that involves this C1 esterase inhibitor is pretty easy because the screening tests are generally available. You don't have to actually do genetic testing. You can do functional tests on the protein itself, and also on the complement. C4 protein is usually low in these patients as well. So it's usually pretty easy to make the diagnosis if the doctor's aware of what it might be, basically.
In order to get HAE, does something have to trigger it? Because, one day you don't have it, and the next day you've got, let's say, massive swelling of your foot or abdominal pain. What is setting this off?
So it's usually a response to trauma, and that trauma may be minor, something that you wouldn't have even noticed, walking around on your feet, which most people do every day, using your hand to hammer something or having, which is the worst of all, having dental surgery or something like that, where you get airway swelling, which is the most feared and dangerous complication of this swelling. You get massive swelling of the tongue and mouth, and the sometimes involving the airway that can be fatal if it's not treated. And so usually it's trauma. This whole system is basically a response to injury that's out of control. It's usually controlled and gives you a little bit of leak and edema in the area that's part of the normal healing process. But in this case, the things that are usually there to control it and keep it from getting out of control are broken.
Are you familiar with RSD, reflex sympathetic dystrophy?
Pretty much, yeah. I've seen some patients.
How does that compare or not? Because RSD could be a minor trauma that sets off a physiologic response that is disproportionate to the trauma.
Right. And, I don't think we really are in touch with exactly how RSD works, but you're right. And I've seen some patients exactly like that, had an injury to a foot, and the foot becomes cold and swollen and extremely painful. And but it's not being triggered by the contact system. My impression is that this is some kind of neurologic abnormality, and I'm not sure that we know exactly what it is, but yeah.
Well, I'll say this: RSD is set off by a hyperactivity of the autonomic nervous system.
Right.
So the autonomic nervous system gets triggered, okay, and then sets off these physiologic changes. So how does HAE work in terms of the immunologic system?
So, so there's another part. I mentioned the complement system, which is which is a cascading system of enzymes in the body that responds to infection or infectious stimuli of one type or another to protect you from infection. The contact system is a response to injury, that normally produces a little bit of leakage in the blood vessels. That's usually controlled, but produces that little bit of swelling that you get when you get, for example, a vaccine or get a blow to your body as you're playing football or something like that. You get some swelling in the area, and that is partly due to the contact system getting activated. There's a whole cascade of events that happen that result in the hold on just a moment. Let me I'm very sorry. Just 1 second.
Take your time. I
do this.
I understand.
I just need to acknowledge something. Okay. Yeah, so there it sets off this cascade of events that culminates in the production of a molecule called bradykinin.
Oh, I'm sorry. Hold on a second.
Go ahead.
Hold on a second.
Okay.
I've made a mistake.
Yeah, so there it sets off this cascade of events that culminates in the production of a molecule called bradykinin.
Oh, I'm sorry. Hold on a second.
Go ahead.
Hold on a second.
Okay.
I made a mistake. You still there?
I'm here.
So I tried to work in the viewers. One of the viewers said that her husband had it affect the throat, and I was trying to get her to be able to participate as well. But that's my goal with DocTalk Live, is to engage whatever audience we have so that they can also get their questions answered. Yeah. So please continue. I'm sorry.
Yeah, no, that's fine. And as that viewer was noting, that is one of the most feared and dangerous complications. I mean, it's not going to cause you any physical harm if your hand becomes the size of a balloon, usually, but if your throat becomes swollen, particularly your airway, the tube, the trachea leading down into your lungs becomes swollen shut, obviously everybody would guess that could be a fatal problem if it's not taken care of emergently. So that is the most feared complication. So
that leads to the question, you've got to diagnose it, you get the diagnosis, how do you prevent it? How do you manage it?
Right. So there have been a variety of medications that have been used over the years, and it kind of depends on how severe the problem is as to how much you need to do. If you're having attacks very infrequently, I mean, and now there are a whole host of biologic medications, and several of them are made from purified human C1 esterase inhibitor from blood plasma, because we got lots of plasma donor companies that purify proteins from all sorts of proteins from blood plasma that are used, and this is one of them. So they'll purify the C1 esterase inhibitor from human donors' plasma. It's very carefully screened, of course, and then there are, so if you're having very infrequent mild attacks, maybe you could just treat those attacks with one of these preparations when you have an attack. You'll go in, you'll either give yourself an injection or you'll get an IV medication. But if you're having very frequent attacks, you may need to go on what's called prophylaxis, where you take a medicine every day or every 2 or 3 days to protect yourself from having an attack, because maybe you have attacks so frequently, and maybe they do involve your throat sometimes. And what would happen if that happened at night when you were asleep? You might suffocate and never even wake up. So it's pretty terrifying.
So problem. The medicine is, if you're taking it prophylactically, do you do it IM, IV? How do you self-administer the medicine?
There are actually all three ways. It's not given IM, but there's subcutaneous products that are for prophylaxis. There's IV products, and there's actually an oral product now that's available. I don't have any experience using the oral product, but all three options are available for people if they need it. Again, it depends on how severe it is and what the urgency is. The one thing about this disease that may or may not be true, but it may or may not be true for an individual patient, but the type of attack that people get tends to be the same type of attack. If you get attacks that involve your gut, they tend to be that type of an attack. And if you get facial swelling or facial or swelling in an extremity. That tends to be it. But if you get airway swelling, that tends to be also the type of attack you get. So kind of depends on how scared you are of what the consequences might be as to whether you would be willing to go on and able to go on to prophylaxis.
And again, this usually presents in adolescence, correct?
Usually, yeah. We've seen young kids with it though, and back in the day when we had very limited medications, it was a huge problem because the medications all had serious toxicities associated with them. If you had to use them, particularly in growing children, it was a problem.
Do
Less so
steroids
for
ever
adults,
help
but
with this? Did you
beg,
ever
beg
use,
pardon?
did you ever use steroids to manage this?
Right. So androgens were the main thing that I had used in the past, and even in children when we had to, for children who were having frequent scary attacks. We've had to use androgens in kids, which are, and particularly for girls, that's a problem. Now, fortunately, we're out of that era. We've got other medications that can be helpful if we can. The cost of these biologics is always more than the small molecules, or frequently more. Let's put it that way. So, but I think things are getting better for this disease. The medications are all there's several of them that are brand new, relatively, in the last several years, and eventually these medications are going to get cheaper and more affordable and better and safer. And I think everything is going in the right direction for these types of patients.
What have you or what has medicine learned from this disease in terms of harnessing, let's say, the plasma? Like in my practice, for instance, I use what's called platelet-rich plasma, where we take people's blood, we spin it, and we capture their platelet-rich plasma, and we re-inject it into their knees. And the evidence is anecdotal. I mean, there's not good evidence that this works, but I will tell you, in my experience, this has been a wonderful way of addressing knee arthritis. So since we're in the plasma, I'm just curious about learning more from an immunologist.
Well, it wasn't obvious, back in the day. And actually, when I was in my fellowship, that was the first trial of purified human C1 esterase inhibitor in patients. I mean, it wasn't clear that you could give purified human C1 esterase inhibitor and it would fix the problem. Maybe the intensity of the inflammation or the swelling that had started in the person's hand or face or whatever was too intense, and giving the inhibitor later would not help. But actually, it does turn out that it helps, and you can substantially reduce the time that the swelling persists by giving that medication. But we didn't know that up front, so we've learned that. We've also learned a whole lot about how the contact system works. Because of the stimulus of trying to understand how does this swelling work, we've discovered new and rarer kinds of inherited types of swelling that involve other parts of the system that I won't talk about because I've never seen one of those patients, but they're definitely out there. There are people that don't have a problem with the C1 esterase inhibitor gene. They have a problem with another gene that's affecting this contact system and causing swelling that looks a lot the same. And some of those medicines that we've now got available to us, the receptor antagonist for bradykinin, for example, is one that should work for those because they're all eventually causing swelling through the bradykinin receptor. So a receptor antagonist, just like an antihistamine, it works when you go out in the spring air and you're sniffing in all that pollen. The antihistamines in the drops that you put in your eyes and the nasal spray and that you take by mouth help a lot with the symptoms.
Have y'all learned anything from COVID over the last year as it relates to the plasma? And
Boy, we are learning so many lessons with COVID, but I don't know of anything I'm sure there's interactions with the contact system with that, with those infections, but I'm not an expert on how the receptor is a different receptor that the virus uses.
and how about why COVID doesn't seem to affect children that much? Why
Boy,
does
that is another great question. And people are speculating actually that it might be a beneficial effect from vaccines. I've seen one line of evidence that says that the MMR vaccine, that there are similar protein shapes in the antigens in the MMR vaccine, but in the measles and the mumps and rubella, all three of those viruses have some similarities to COVID. It may be that vaccine is actually providing young children with some immunity. I don't think that's a proven. I've seen that hypothesis put forward, but we do see other viral infections that are mild in children. For instance, varicella in young children, infants, and so forth. You've probably seen young children usually have pretty mild case. You get an adult that hasn't had varicella that gets varicella, there could be in the hospital, deathly ill.
Varicella is chickenpox,
Oh,
right?
sorry, yeah, so chickenpox, right. Yeah.
This is stretching my
right.
my
Right.
memory banks from
Sorry.
way back when.
Yeah.
Well, let's shift gears. I want to hear about paleontology. How did
Don't
you
get me started.
How did you get into that?
Well, I mean, like a lot of people, I'm an amateur, so I don't call myself, don't have any official credentials, but a friend of my mother's gave us some shark's teeth when I was a kid, and I got fascinated by these, beautiful objects that from animals from long past days long past, and I went out and started combing the area in the creeks nearby where I lived, and eventually, the whole area, and I went off for a while and went to medical school and college and got busy and couldn't. But now that I'm back and I'm established in my career, and I have a weekend every once in a while that I can do something, I still love going out and hunting.
Hunting, and you like to hunt. Was it dinosaur bones? What was it?
Oh, yeah. So can I say the name of the organization that I go with? Or
absolutely.
It's a nonprofit called the Bighorn Basin Paleontological Institute, or BBPI. And they're one of several nonprofits that have permission to hunt for fossils on land owned by the federal government out west. And so they go out and do controlled excavations on federal land, which you have to have permits for. And the material that you get there, some of the material, like invertebrate material, plant material, you can bring limited quantities of that home. But any vertebrate material, I think, from federal property, I think is supposed to go to a museum. You shouldn't pick that up really and there's no really any point to bring home and putting something on your mantelpiece. I really don't enjoy that. I love taking photographs and just doing it and finding something that nobody's seen before, which we do. We see stuff that nobody's ever seen before, new stuff. What
is your favorite fossil?
Oh boy, I don't know. They're all so beautiful.
I'll tell you mine. Are you familiar with the Taski Stone?
Yeah, I have a couple of those that some other friends of my parents gave us. Yeah, I have those. Those are gorgeous.
I love Petoskey stones, and the reason is it looks like a rock, and then you put it underwater, and it's like a piece of art comes out of it.
Yes, it is. So they are so beautiful, and there are lots of, I mean, everything. Many of these ancient types of fossils have their own beauty, and just the thought that you're seeing something that was alive so long ago, I think is just really, really thrilling to me.
Well, I want to thank you for taking the time. I want to plant the seed, Prescott. I know that you don't do Facebook, but as we put this out over the Facebook air, people will call in questions. So I might have to email you looking for answers because, like I said, maybe prior to the show, I'm trying to get information out there for our listeners about hereditary angioedema, which is clearly quite uncommon, but now more readily diagnosed if people know to look for it.
Sure. Well, I'll be glad to help.
Thank you so much, Prescott. Thank you for taking the time.
Oh, my pleasure.
Awesome. All right, I'm going to hit end. That should end our stream, I think. Hold on. I might lose you as I end it on Facebook.